percutaneous renal surgeries. So there are 3 approaches. First, the use of nephrostomy tubes. Second, tubeless with ureteral stent use and no drainage tube. So nephrostomy tubes, there are different types of nephrostomy tubes. One is balloon catheters. So we have the Foley catheter, the one we usually see as ureteral catheters in the hospital, and the council catheter. So the council catheter has an advantage because you can put a small caliber catheter into the tip to extend it into the ureter for better anchoring. Then retention balloon, which is usually at 5 ml, should not be fully inflated, and saline or water should be used to inflate it. Next, the Cope catheter. It has a pull string coil mechanism. It has better retention, and the risk for dislodgement can be reduced by placing the retention loop in a polar calyx rather than the renal pelvis and by using a nephrostomy tube with extension down the ureter. Next is the Malicot catheter. So as you can see, there are expanded wings which provide a traumatic and non-obstructive retention mechanism. So when placed or removed, a stiffener is inserted through it to push the tip to straighten the wings. So it is also available with an extension that is directed down the ureter, the re-entry nephrostomy tube. Fourth, we have the nephroureteral stent. So this tube continues to a ureteral extension and to the bladder. So it has excellent control of the entire upper urinary tract and is unlikely to become dislodged. Last is the circle catheter. So it is secure, easily exchanged, causes little trauma, rarely occludes and provides excellent drainage and an avenue for irrigation of the renal pelvis. So it requires 2 percutaneous skin access sites, and it is most useful for maintenance of 2 tracts, such as those for irrigation and if a second look nephroscopy is desired. So advantages of nephrostomy tubes include good drainage and control of the upper urinary tract. There is maintenance of percutaneous access for additional procedures and additional diversion of urine in cases of large perforations during the procedure. So we have small caliber nephrostomy tubes, which are French 8 to 18, and large caliber nephrostomy tubes, French 20 to 24. Small caliber nephrostomy tubes are associated with less pain than large caliber nephrostomy tubes and are not associated with any increased hemorrhage. On the other hand, removal of larger tubes occasionally can be followed by immediate hemorrhage. It should be removed in a radiology suite where there is an opportunity for immediate replacement of the tube. However, small caliber tubes can be removed safely at the bedside after a period of clamping to assess clinically for distal ureteral obstruction. So general considerations with the use of nephrostomy tubes. All nephrostomy tubes should be anchored to the skin externally with a suture or other mechanism to help prevent dislodgement. But internal dislodgement is all patients, especially when they are moving, since the kidneys and the skin has a bigger, are more wider apart. Choice of catheter should be decided considering the size of the patient, the importance of maintaining a drainage, and the desire for ureteral intubation. The next approach is a tubeless with ureteral stent. So there are internal ureteral stents that is removed cystoscopically, an internal ureteral stent that is removed by string exiting the flank, and externalized ureteral stent that is removed along with the urethral catheter where it is attached. So its advantages compared to nephrostomy tubes: decreased pain and analgesic use, avoidance of an external drainage device, shorter hospital stay, and decreased healthcare costs due to shorter hospital stay. Disadvantages would be loss of percutaneous tract for a secondary procedure, the cost of the device itself, inconvenience and discomfort associated with an internal ureteral stent that requires cystoscopic removal. So in comparison, a use of a ureteral stent instead of a large caliber nephrostomy tube is associated with reduced narcotic use and decreased length of hospitalization. The benefit of nephrostomy omission is less apparent, though, when compared with a small caliber nephrostomy tube. So in properly selected patients, use of a ureteral stent instead of a nephrostomy tube does not affect stone-free or complication rates. It is not advisable for patients with significant bleeding or perforation if a second percutaneous procedure is anticipated. So it is indicated for those who do not need external drainage. Samples are significant bleeding, significant collecting system injury, and those who are unlikely to need a secondary procedure. The last approach is the no drainage tube. So it is a totally tubeless percutaneous renal surgery omitting both the nephrostomy tube and ureteral stent. So this can be considered only in a selected number of patients, those with low volume stones, a traumatic single access, and no hemorrhage, perforation, or obstruction. So its advantages, similar to the ureteral stent, decreased pain and analgesic use, shorter hospital stay, shorter time to return to normal activities without increasing complications, decreased healthcare costs secondary to shortened hospital stay. So one of the concerns with any procedure or approach that omits the nephrostomy tube after percutaneous renal surgery is that of hemorrhage from the tract. Evidence from randomized controlled trials suggests that the size or presence of the nephrostomy tube does not affect the degree of post-op bleeding. There is still a potential for dramatic bleeding for any percutaneous procedure, and bleeding would be more problematic without a nephrostomy tube in place. So adjuncts used usually for hemostasis include placement of a fascial suture, direct monopolar cauterization of the tract, cryotreatment of the tract, insertion or installation of hemostatic agents. Randomized studies have failed to show an impact on post-op bleeding with the use of tract sealing agents. Thus, their utility in routine practice remains questionable. So special situations include horseshoe kidneys, pelvic ectopic kidney, and transplanted kidneys. So for the horseshoe kidney, so CT MRI or MRI should be considered for pre-op assessment. So since anatomically it has a more prominent antero-posterior tilt, making the upper pole the most superficial and posterior aspect of the horseshoe kidney, an upper pole access is useful for this kind of kidney. Lower pole calyces are usually not safely accessible with direct percutaneous puncture. So pelvic and ectopic kidneys, they can be kidneys from the pelvis and to the thorax. So supine positioning and transabdominal access is beneficial for pelvic kidneys. CT or MRI could be used as guidance for safe access. So rarely, laparoscopic robotic assistance may be required to mobilize overlying bowel such that the kidney can be safely punctured. There are simpler alternatives to laparoscopic assistance though. So for example, this one, supine oblique positioning with a pad under the ipsilateral hemipelvis using and with the guide of an ultrasonography to assess where the intervening bowel could be used. And this one, if the bone is does not intervene between the appropriate calyx and the skin, a posterior approach can be used just above the iliac bone or through the greater sciatic foramen with a transgluteal approach. For transplanted kidneys, usually the anterior location of the ureteroneocystostomy and short ureteral length makes the retrograde access for contrast challenging. So initial puncture is best guided by an ultrasound. The pelvic location of transplanted kidneys almost always mandates an anterior approach with the patient in supine position. Dense fibrosis surrounding the transplanted kidney could be resistant to standard balloon tract dilation. So fascial incising needle coupled with balloon dilation or use of telescoping metal dilators may be necessary when doing this procedure to transplanted kidneys. Let us now go to complications of percutaneous renal access. First is acute hemorrhage. So this is the most common significant complication. So associated factors would be patient characteristics, multiple access sites, supracostal access, increasing tract size, tract dilation with methods other than balloon dilation, prolonged operative time, and renal pelvic perforation. It is also important to note the medication history of the patient as what previously discussed to prevent bleeding. So the renal parenchyma, it could bleed easily, and proper entry and dilation by careful manipulation of the sheath should be observed to prevent it. So post removal of the tract sheath, there could be intraparenchymal vessel bleeding. Cauterization or placement of hemostatic material could be used, but the best approach would be to insert and occlude with a nephrostomy tube, apply pressure to the incision, and let the collecting system clot off. So those refractory to hemostatic measures, the use of a K nephrostomy tamponade balloon is warranted. So for venous bleeds, a console catheter as a nephrostomy tube could be inserted with the balloon inflated slowly at the site. Then a gelatin matrix hemostatic sealant is instilled, and the second catheter with balloon is inserted just underneath the skin surface to seal the tract. For large venous bleeds, large bore catheter through the injury site into the main renal vein, and then back it out several days later. For small arterial injury, fulguration under direct vision, so this is cauterization under heat, and selective angioembolization will be likely required. So delayed hemorrhage. So any report of bright red blood in the urine or nephrostomy tube after surgery should raise clinical suspicion for AV fistula or arterial pseudoaneurysm bleed. So usually 1 week post-op, if a patient reports flank pain associated with hematuria, usually if bleeding is associated with clot formation, which can cause obstruction and mimic renal colic. So diagnostic would be angiography, and treatment would still be selective angioembolization. Another alternative treatment offered in Campbell's is placement of a covered stent to occlude the site of arterial injury. So for collecting system injury, so infundibular tears usually do not cause problems as long as there is no hemorrhage. Ureteral injuries, they are rare and usually the result of inflating the balloon in the ureter. So a ureteral stent placement is warranted for healing of the injured ureter. So renal pelvic perforation, so it is usually caused by pushing on a renal pelvic stone too hard or misusing a lithotrip resectoscope. So collapse of a previously distended renal pelvis is a usual sign if perforation is not visualized directly. If not detected intra-op, watch out for post-op abdominal distension, ileus, and or fever. So if seen intraoperatively, it is prudent to abort the procedure unless it is near completion. Insert a nephroureteral stent or a nephrostomy tube plus an internal ureteral stent to optimize drainage, and then wait 2 to 7 days before nephrostography and tube removal. So post-operatively, if there is renal pelvic perforation, there would be urine leaks. And urine leaks could cause lipolysis and encapsulating of the urine, causing urinomas. So placement of a percutaneous drain could be is warranted for urinomas, but but urinomas are usually resorbed based on readings. Visceral injury, any abdominal organ close to the kidney can be injured, like the colon, duodenum, jejunum, spleen, liver, and biliary system. So for the colon, left is injured twice as often due to the anatomical placement of the kidney in the left colon. Usually involves access to the lower pole. Risk factors include advanced age, dilated colon, prior colon surgery or disease, thin body habitus, and the presence of a horseshoe kidney. So it is less likely to happen with supine positioning. So post-op signs and symptoms would include unexplained fever, prolonged ill use, unexplained leukocytosis, rectal bleeding, evidence of peritoneal inflammation, or fecaluria or pneumorrhea. Most are extraperitoneal and can be managed conservatively. So prompt and separate drainage of the colon and urinary collecting system. So nothing by mouth for a few days, and then start clear liquids and advanced diet as tolerated. So for those with intraperitoneal involvement and when with peritonitis or sepsis, open surgical repair is warranted. For small bowel injuries, these are less common. In signs and symptoms of peritonitis and a note of noting a nephroenteric fistula during post-op nephrostography. So this is still managed conservatively. Percutaneous intraduodenal, this could be managed conservatively by percutaneous intraduodenal catheterization or simple nasogastric or nasoduodenal drainage, combined with drainage of the upper urinary tract, fasting, and parenteral feeding. So for intestinal injury, it is always, for the conservative management, it would be a separate drain for the intestines and a separate drain for the upper urinary system for the fistula to heal, and then bowel rest should also be employed. Splenic injuries, so access above the 10th rib. So if you are aware that the patient has organomegaly, CT guidance is recommended. So rarely it requires laparotomy and potentially splenectomy if there is massive hemorrhage. So hepatic injury is less likely associated with significant hemorrhage, and splenic injuries and hepatic injuries can be managed conservatively. So its conservative management would be serial abdominal examinations and complete blood count measurement. However, gallbladder or biliary tree injury can lead to biliary peritonitis, and it is associated with high mortality rates. Hence, exploratory laparotomy or laparoscopy and cholecystectomy is warranted. Pleural injuries, so these are often detected with chest fluoroscopy during or at the conclusion of the procedure. So hydrothorax and occasionally pneumothorax. So supracostal access is the main risk factor, and access above the 11th rib or higher carries a much greater risk for PIG. Thoracostomy is not necessarily needed for all patients with hydrothorax. If noted intra-op, a small caliber French 8 to French 12 Cope nephrostomy tube as a thoracostomy under fluoroscopic guidance, attached to a Heimlich valve if no lung injury is noted. However, hydrothorax is seen post-operatively in the chest X-ray. A small caliber tube is only inserted if the effusion is large or there is respiratory compromise or hemodynamic instability. Nephrofistula or urinothorax is a direct and persistent communication between the intrarenal collecting system and the intrathoracic cavity. So it is commonly diagnosed after percutaneous tube removal. Metabolic and physiologic complications include intravascular hemolysis, hyponatremia and other electrolyte imbalance, renal or hepatic dysfunction, and mental status changes. Usually these are caused by intravascular or extravasation of non-electrolytic isotonic fluids from continued irrigation in the setting of a large venous injury or collecting system perforation. Hence, isotonic normal saline is recommended as an irrigant. However, even with normal saline as an irrigant, there is still the risk of volume overload. Hence, judicious fluid irrigation should be observed. Another complication would be venous gas embolism. So watch out for hypoxemia, evidence of pulmonary edema, increased airway pressure, hypotension, jugular venous distension, facial plethora, dysrhythmias, and auscultation of a meal wheel, cardiac murmur, and or appearance of a widened QRS complex with the right heart strain patterns and electrocardiography, since most venous gas embolism are confined in the right chambers of the heart. So for right chamber, usually this would cause hypoxemia and hypercapnia and depressed cardiac output. If the patient has a patent foramen ovale, however, it could go into the left chamber directly and cause neurologic deficits or stroke. So the most sensitive measure would be capnometry reading of the end-tidal carbon dioxide. So management would be rapid ventilation with 100% oxygen, positioning the patient's head down with the right side up to confine it to the right ventricle for easier removal or aspiration, and general resuscitative maneuvers. So post-op fever and sepsis. So risk factors will include diabetes mellitus, paraplegia, indwelling stent or nephrostomy tube, any urinary tract manipulation, stones, pre-op urine culture, and hydronephrosis. So usually those patients with fever post-operatively are just experiencing SIRS or systemic inflammatory response syndrome, which is a non-specific immune response So it is specifically defined by 2 or more of the following conditions. So temperature greater than 38.5 or less than 35, heart rate of greater than 90 beats per minute, respiratory rate of greater than 20 beats breaths per minute, or PaCO2 of less than 32 millimeters mercury, and WBC counts of greater than 12,000 cells per ml or less than 4,000 cells per ml, or greater than 10% immature band forms. However, sears in response to a documented infection, for example, positive culture and gram stains, or for any positive sterile fluid for pathogenic microorganisms, it is already considered as sepsis. So positive pre-op urine culture should be treated. So if pus is aspirated upon initial percutaneous entry, upper urinary tract, the safest measure is to abort the procedure and leave a nephrostomy tube for drainage. Neuromusculoskeletal complications. So these are caused by excessive pressure on the neural and vascular structures, either directly from the operative table or indirectly from positioning of the limbs, which may cause short or long-term disability. For the head and neck region, so this includes ocular injury resulting in visual loss, facial nerve injury or necrosis over facial bones or the tip of the nose, CVA caused by carotid or vertebrobasilar artery dissection. So careful padding of the head in a neutral and non-extended position should be observed. Brachial plexopathies, this could be prevented by, and the shoulder and elbow should not be abducted more than 90 degrees, and generous padding at the elbow and forearm reduces the risk of nerve compression. For the knees and the feet, knees need to be padded, ankles should be elevated to reduce pressure in the dorsum of the foot. Collecting system obstruction, so predisposing factors include large stone burden requiring multiple or long procedures, and prolonged nephrostomy tube drain, previous open stone surgery, diabetes mellitus, and obesity. So transient ureteral obstruction should caused by ureteral edema or blood clot is common, and nephrostomy tube should be removed only after nephrostography or after a period of clamping to assess clinically for distal ureteral obstruction. Stricture formations, usually at the uretero-pelvic junction or in an infundibulum, usually managed by endoscopic treatment. But open surgical reconstruction or excision of partial nephrectomy or total nephrectomy may be required for some cases. So loss of renal function. Percutaneous renal surgery causes no significant change in function of solitary kidneys. So this could be also be loss of renal function is also attributed to iatrogenic causes. For example, selective angioembolization, which is not selective enough, causing ischemia and necrosis of the renal units. Venous thromboembolism, the incidence is low, less than 3. Still, early ambulation is used to prevent. Extremely rare, that is extremely rare, and when it occurs, it is usually caused by underlying cardiovascular conditions. So another axis is the retrograde renal axis and drainage. So it is from below to up, so either from the urethra, bladder, ureter. So indications, just the same indications as percutaneous. So renal drainage such as in renal obstruction, often placed after routine ureteroscopy for stone disease after multiple reconstructive surgeries. So general considerations, obtain urinalysis for pyuria, treat an infection before intervention, antibiotic prophylaxis in all patients undergoing cystoscopy with ureteral instrumentation, dorsal lithotomy position affords the surgeon ready access to the external genitalia and the perineum. So materials, they come in flexible polymers such as polyurethane, silicone, and metals. So design vary. There are self-retaining double pigtail, single pigtail urinary diversion catheters, open-ended spiral tip ureteral catheters, and Polaris loop ureteral stents. So there we have a ureteral stent symptom questionnaire. It measures the impact of ureteral stents on patient quality of life. So in studies who used USSQ, There were reported limitation of daily activities due to pain, some degree of sexual dysfunction, and decreased ability to work. Increased length corresponded to bladder symptoms of urgency and frequency, but no difference in flank discomfort. However, in recent studies using USSQ, there was no difference in urinary symptoms and flank discomfort. So for the diameter, there was no association with pain and stent-related discomfort. And the use of alpha blockers and antimuscarinic agents were associated with improvement of bladder symptoms such as urgency and frequency. Thank you.
Thank you, Ian. I just have 2 questions for you. So personally, what do you think is better? A nephrostomy tube or a stent?
Nephrostomy tube, sir.
Sorry?
Nephrostomy tube.
Why?
It offers greater drainage po, sir, and it has bigger calibers po compared to your literal stent. Actually, it depends po kasi on the assessment po during operative assessment. Kung ano yung, kasi advantages naman po ng ureteral stent is yung hospital stay and the like. Pero it depends on the injury po or the need actually for me.
Yeah. There's 2 points for a nephrostomy tube versus a stent. So number 1, which do you prefer? Do you prefer something that, so for a nephrostomy tube, naka-perk yan eh. So naka-connect sa'yo. So I think they prefer a stent during this time because may parang actually yung sa amin sinasabi nila parang death sentence daw pag may nakakabit sa'yo such as mga colostomy, urostomy. So I think stent is better for some patients, but I do get your point based on your report. Now, on what instance would you choose a nephrostomy tube over a stent?
Over a stent. For severe po na, ano ba yun? If you need a greater, ano ba yun? Redirection of the urine po, sir?
Hindi, parehas yun, redirection of the urine. Both of them, you bypass your urine. The point I'm getting at is very practical, so hindi mo kailangan mag-isip. Anong anesthesia mo sa nephrostomy tube?
Sir, sorry, sir.
Anong anesthesia mo sa nephrostomy tube?
GA?
Ha?
GA?
Pwede ka mag-vocal.
Okay, pwede.
For the stent, you need, local din, pwede, pero spinal or epidural or GA. So, where I'm driving at is pag stenting, kailangan mong mag-cystoscopy ka yan eh. Kailangan mo siya ipasok sa OR.
Okay.
Okay? So, for example, I give you a case. Known PUI, known COVID positive. So, anong pipiliin mo?
Nephrostomy tube.
Yes, fast in, fast out.
Yes.
So you can easily do that locally with an ultrasound based on your report. Actually, yung report mo nga sinabi, MRI, CT scan, you can easily do that. And based on your report last Wednesday, you can do it blindly, remember? But we've never seen. Yeah, pwedeng blind. So it's very easy to do, especially in those times na, especially with the anesthesiologist, the surgeon, when you do it in the OR. That's why my first question was, what do you think is better? So obviously, personally, and based on from our experience, mas okay sa patient yung stent kasi hindi nga nila nakikita. The problem with the stent is the irritation. You mentioned that on the last part of your report. May urgency, di ba? Tsaka frequency. That's the problem with the stent. So, yeah. Who's the next lecture? Good report, Ian. Thank you. Let's proceed with the next. Ganda ng slide. Gumagalaw.
Hello, so good afternoon. Today we will be discussing about the fundamentals of laparoscopic and robotic urologic surgery. So diseases that harm require treatments that harm less. That's why there have been an increasing number of multi-institutional studies that have emerged comparing laparoscopic and robotic procedures with their open surgical counterparts and showing equivalent efficacy and acceptable efficiency, as well as the distinct advantages of decreased post-operative pain, improved cosmesis, expedited recovery, a shorter hospital stay, and as techniques evolve and mature, in many cases, lower cost. So for your preoperative preparation, you should do careful patient selection and identification of contraindications for lap and robotic procedures, because these are vital for successful outcomes. So a meticulous past history focusing on prior surgeries and physical examination, detailing the location and extent of all abdominal scars, are the initial steps in patient evaluation for minimally invasive surgery. So your contraindications to lap or robotic surgery include uncorrectable coagulopathy, intestinal obstruction unless treatment is intended, significant abdominal wall infection, massive hemoperitoneum or hemoretroperitoneum, generalized peritonitis, and suspected malignant ascites. Next, please. So these are the things that you must take into consideration if you're considering lap or robotic surgery. So first is morbid obesity. So you may encounter problems such as inadequate length of instruments, decreased range of motion of the trocars and instruments, the need for higher pneumoperitoneum pressures to elevate the abdominal wall, poor anatomic orientation owing to excessive amounts of adipose tissue. However, studies have shown for laparoscopic adrenalectomy and nephrectomy in obese patients that the laparoscopic group had significantly superior outcomes regarding blood loss, resumption of oral intake, and ambulation, as well as narcotic analgesic requirements, median hospital stay, and convalescence. So for your extensive prior abdominal or pelvic surgery, the palmar point is the preferred site for varus needle insertion with the suspicion of extensive intra-abdominal adhesions. In cases of suspected adhesions, a retroperitoneal approach may be preferable or initiated retroperitoneally, and the peritoneum is entered via the retroperitoneal axis. So for your pelvic fibrosis, it may constitute severe technical challenge when surgery of the lower urinary tract is indicated. For ascites, risk of injury to the bowel because of the close proximity of the bowel loops to the anterior peritoneum. Watertight wound closure and firm wound dressing should be done to prevent prolonged post-operative leakage. So next, please. For your organomegaly, it needs cautious approach when obtaining pneumoperitoneum. So the site of varus needle insertion must be at a safe distance from any enlarged organs, or open access with Hassan cannula may be considered. Must be at a safe distance from the fundus of the uterus. And trocar placement is usually more cephalad on the abdominal wall. So your preferred site of access is in the left upper quadrant in the subcostal of the midclavicular line. Next, please. So next, please. Prolonged intra-abdominal pressures of more than or equal to 15 millimeter mercury can lead to hypotension, and prolonged CO2 pneumoperitoneum should be avoided because it can cause maternal hypercarbia and acidosis, and it may affect the fetus. So second trimester is the preferred time for surgery because of the completion of fetal organogenesis, plus there's a reduced chance of inducing labor. Next, please. So for your iliac or aortic aneurysm, if the aneurysm doesn't require immediate correction, insertion of the Ferris needle should be on the left upper quadrant to stay away from the area of the aneurysm. Open access with Hasson technique can be used, and insertion of accessory trocar must be done under endoscopic control to avoid the area of the aneurysm. So for your preparations, the need for a full mechanical and antibiotic bowel preparation becomes an issue only if one anticipates encountering dense intra-abdominal adhesions or if surgery involves entering the bowel. So for your enhanced recovery after surgery program, it includes overnight fasting to avoid solid food, 6 hours before surgery, carbohydrate drinks 2 hours before surgery, management of fluids to seek balance rather than large volumes of intravenous fluid, early removal of drains and tubes, early mobilization, and the consumption of food and drink on the day of the operation. These protocols have resulted in shorter hospital stays, a reduction in complications, a decrease in readmission rates, thus reducing healthcare costs. So more extensive laparoscopic robotic procedures should be managed like any other major open surgical procedure with packed red blood cells available before surgery. Next, please. So in your operating room, the setup of the operating room must provide enough space for all personnel and equipment required. All equipment must be fully functional and in operating condition before procedure is started. And a separate tray with open laparotomy instruments must be ready for use in the event of complications. For your patient positioning, it depends on the procedure. For your supine, the arms must be tucked snugly at the sides or at rest on sleds. For your Trendelenburg or lateral, tape and security belts should be applied across the chest and thighs, and point of contact with the table must be padded. In lateral, the bottom leg is flexed approximately 45 degrees while the upper leg is straight. Next, please. Pillows should be placed between the legs as cushion and to elevate the upper leg so it lies level with the flank. And pads between the table and knee and the ankle of the lower leg should be placed because these are high pressure areas. So for your lateral decubitus, used, and during the procedure, an active warming system may be used to prevent hypothermia in lengthy procedures. So BMI greater than or equal to 25, the use of a kidney rest and a full table flexion were associated with increases in interface pressure. And of these, the use of the kidney rest was believed to be the most detrimental, and its use beyond 20 to 30 minutes was discouraged. Next, please. So for your prophylaxis and other preparations, pneumatic compression stockings can be used. They are an anti-embolic prophylaxis, and the administration of 5,000 units of subcutaneous heparin preoperatively is an option. For high-risk patients, both may be considered and continued postoperatively. And a Foley catheter insertion allows for accurate measurement of your urine output, and it reduces the risk of injury with pelvic procedures. Next, please. So for your operative team and equipment, the main laparoscopic cart should contain the insufflator, the light source, camera controls, and any recording device. Ideally, the insufflator should be placed at the surgeon's eye level to allow continuous monitoring of the CO2 pressure. So endoscopy equipment offer integrated systems that consist of flat panel displays and equipment towers mounted on adjustable ceiling booms. The tower containing the light source, camera system, and insufflator can be placed in any area around the patient depending on the operation at hand. Next, please. So in this picture, on your left, you can see a standard laparoscopic cart, and on your right, an integrated laparoscopic vision system. Next, please. So for the placement of the operative team, for your transperitoneal procedures of the upper abdomen, for your laparoscopic, the patient must be placed on modified lateral decubitus. The surgeon and assistant in front of the abdomen, and the nurse and instrument table at the opposite of the patient at the foot of the bed. For your robotic, patient must be on modified lateral decubitus, the assistant in front of the abdomen, and the nurses and instrument table at the foot of the bed at the same side of the patient. Next, please. So for your laparoscopic, incoming lines from insufflator, suction, and irrigation and electrosurgical devices enter from the contralateral side of the table or from the ipsilateral head of the table. For your robotic, all incoming lines and devices enter either from the contralateral foot side of the table or the ipsilateral head of the table. Next, please. So for your retroperitoneal procedures in the abdomen, for your laparoscopic, the patient should be placed on true 90-degree lateral decubitus with the body at right angle to the table, and the table is angled at the hip to accentuate and increase the distance between the 12th rib and the iliac crest. And the surgeon and assistant stand facing the patient's back, and the scrub nurse and instrument tables are facing the patient's front, and the instruments are handed across the patient. For your robotic, also in true 90-degree lateral decubitus, the assistant should stand facing the patient's abdomen or back depending on the port placement, and the scrub nurse and instrument table should be on the same side as the assistant near the foot of the table. Next, please. For your transperitoneal and extraperitoneal pelvic procedures, for your laparoscopic, the patient is in supine position with legs on split leg positioners or elevated stirrups that have knee and leg supports to avoid peroneal nerve injury. The arms must be tucked at the side, and there must be a snug chest strap. The surgeon and assistant at the side of the table where he or she is comfortable, and the assistant at the opposite side. For your scrub nurse and instrument table, the table must be at 30-degree Trendelenburg position. For your robotic, the patient must be at Trendelenburg position with the legs on the split leg positioners or in Allen stirrups, and the robot will be between the patient's leg. The assistant is on either side of the table depending on the surgeon's preference, and the scrub nurse and instrument table at the same side as the assistant to facilitate passing of the instruments. Next, please. So before your initial incision, there should be a essential, and it must be completed before initiation of hemoperitoneum. Ensure that all plugs for the console, vision cart, and patient side cables connecting these cards are connected properly. The 3D camera and endoscope should be calibrated, the image black and white balanced, and the target alignment performed according to the manufacturer's instructions. The side card should be draped and ready. Next, please. For achieving transperitoneal access and establishing your pneumoperitoneum, for your close technique, you have your Veress needle. It can be disposable or non-disposable, and you should ensure proper needle function. The tip test in the needle is connected to the CO2 line. Saline is flushed through the needle with the tip manually occluded so that there is no leakage at the juncture between the shaft and the hub of the needle. The needle should be grasped mid-shaft and passed perpendicularly through the skin using a gentle, steady pressure. You should encounter 2 points of resistance, your abdominal wall fascia and the peritoneum. For your OP, have your Hassan technique. In the unscarred abdomen with the patient in supine position, a 2 centimeter semicircular incision is made at the lower edge or slightly below the umbilicus. The fascia and the peritoneum are opened individually with a transverse incision sufficient to accommodate the surgeon's index finger. Then 2 O-silk traction sutures are placed on either edge of the fascia. Next, the Hassan cannula is advanced through the incision with the blunt tip protruding. The funnel-shaped adapter of the Hassan cannula is advanced, and it is then tightened onto the cannula with the attached screw, and fixation to the abdominal wall is done with the fascial sutures that are wrapped around the struts of the funnel shape adapter of the Haston cannula. So for your hand port access, the pneumoperitoneum can be obtained before or after making the hand port incision. It begins with making a standard midline or lower quadrant incision at the planned hand assist site. The peritoneal cavity is entered in the standard open surgical fashion, and then the hand assist device is placed according to the manufacturer's instruction. And then a blunt cannula is passed through the hand assist device and a pneumoperitoneum is established. Next, please. So for your access technology, you have your TROCARs. It enables introduction of working instruments into the gas-filled abdomen or retroperitoneum. They maintain pneumoperitoneum by conveying the insufflant and serve as a pathway for delivering small amounts of dissected tissue from the surgical area. It consists of an outer hollow sheath and an inner obturator, which is removed as soon as the outer sheath has entered the peritoneal cavity. Next, please. So, a technologic advance in trocar and insufflation technology has addressed some of the limitations of existing trocar systems, including air leak, the need for reducers, and specimen removal. So, your air seal system provides more stable pneumoperitoneum despite continuous high flow suction, trocar dislodgement, or excessive port side leakage. Its valve-free design allows smudge-free scope insertion, intact specimen removal, and easy insertion and withdrawal of instruments of varying sizes. It provides continuous smoke evacuation without the fear of venting surgical smoke and plume into the OR. Next, please. For your hand assist device, the most common are your gel port and endopath dextrose. So compared with standard laparoscopy, pain and numbness of the surgeon's hand, wrist and forearm, as well as overall fatigue are much greater with the use of hand assist device. Both devices maintain peritoneal gas pressure while allowing the insertion of your surgeon's hand or instrument in the abdominal cavity. Next, please. So for your trocar placement, for the placement of your initial trocar, Varus needle technique, you can use it, and the incision is made for the placement of the initial trocar. The trocar is held in the dominant hand with the middle finger extending along the shaft, and it is inserted using a twisting downward motion. And your non-dominant hand can be placed at the level of the skin, gently holding the trocar to stabilize it and prevent sudden advancement. So the proof of entering the gas-filled intraperitoneal cavity is the sound of CO2 escaping from the open sidearm. And after the sidearm is closed, obturator is removed and the CO2 insufflation line is connected to the side port of the trocar. When open technique is performed to obtain pneumoperitoneum, the Hasson-style cannula also serves as your initial trocar. The first step before secondary trocar placement is the inspection of the entire abdomen systematically to rule out any injury to the underlying viscera that may have occurred during access or placement of the initial trocar. After this, the surgeon can proceed with the secondary placement. It is ideal to place the ports in 4-point diamond pattern, so the site of operation is encircled within the diamond. You should place each port so it is pointing towards the surgical field to avoid continued forceful redirection of the port during the procedure because it can cause widening of the tissue tract around the port and subcutaneous emphysema. And the standard approach is done under direct optical control. The 30-degree lens is ideal because turning the lens 180 degrees away from the surgical site provides panoramic view of the anterior abdominal wall. With the blade, incision is made wide enough to accept the selected cannula, and ports should be directed towards the intended surgical field to provide tension-free maneuverability of the laparoscopic instruments. Next, please. It is then advanced through the abdominal wall using slow twist, and constant pressure. Each port passed into the peritoneal cavity should be under meticulous endoscopic monitoring. And to prevent dislocation, it may be anchored to the skin using number 2 non-absorbable sutures. So you should never use a metal choker in conjunction with an outer plastic retaining ring because stray current can no longer be harmlessly dissipated through the metal cannula directly to the surrounding perichoker abdominal wall. Therefore, any juxtaposed visceral structure may be damaged in an area remote to the laparoscopist's vision. Next, please. For your laparoscopic instrumentation, instruments for visualization, to create laparoscopic image, you should have your laparoscope, light source, camera, and monitor. And to record your image, you have your video recorders, digital video disc, and video printers. So for your laparoscope and camera, for your standard system, 30-degree lens provides surgeon with a more complete view of your surgical field, allowing to peer around vascular structures by rotating the lens. And image transmission uses an objective lens, a rod lens system with or without an eyepiece and fiber optic cable. To prevent fogging of the laparoscope, it should be warmed before passing into the abdomen. Several methods for this include using a container holding warm saline or using a warm thermos. So for your instruments for grasping and blunt dissection, grasping instruments have either single action, wherein one jaw moves, or double action, wherein both jaws move. And tip designs include blunt coarse, pointed, straight, curved, and angled. So depending on the size of the handle, grasping instruments may be locking or non-locking. Most non-locking forceps have a scissor-type handle. Different designs allow for locking capabilities, in particular your bar-type and spring-loaded locking handles, and are convenient when prolonged grasping of tissue is required. And other dissectors offer additional degrees of freedom by means of an articulating joint through the wrist movements of the surgeon. Next, please. For instruments for incising and hemostasis, you have your laparoscopic scissors, scalpels, electrocautery, ultrasonic devices, and lasers. And they are used to cut tissue during lap surgery. First, vessels are sealed and occluded with denatured protein. For example, you have your electrosurgery and lasers that denature protein by heating tissue with electric current at very high temperatures. For your sharp dissectors, the blades of your laparoscopic scissors are shorter. For your hook tip, they are used for cutting sutures, micro scissors for spatulating ureter during pyeloplasty, your curved tip used for dissection, and the shaft of your scissors may rotate or articulate up to 90 degrees. From devices, your needle electrodes create fine cuts in peritoneal incisions, your spatula electrodes for blunt dissection and cutting, hook electrodes for dissection of vessels because tissue can be pulled away from the delicate structures before cutting current is activated. Next, please. So, avoid dangers of stray currents from the use of monopolar electrosurgical equipment by using and you should use monopolar current with active electrode monitoring because there is an ongoing feedback during activation of the current. So any break in insulation of the shaft results in the immediate deactivation of the instrument. For your bipolar electrosurgical devices, they require less energy for performance, and there is a decreased likelihood of injury to surrounding tissue because electrical current is only passing from one jaw of the instrument to the other, precluding potential problems of capacitive coupling. The extent of coagulative damage is also less. For your laser instrumentation, typical lasers are not Typically, lasers are not used in urologic laparoscopy, where they have largely been supplanted by electrosurgical instruments. Next, please. For your ultrasound instrumentation, it provides an attractive alternative to monopolar electrosurgery for working around delicate tissues or in patients with implanted pacemakers or cardioverter defibrillators. Electrical energy is transformed into mechanical energy, and the vibrations created are capable of causing cavitation, coaptation, coagulation, and cutting in the targeted tissue. Its advantages include absent risk of local thermal damage and tissue charring, a reduced rate of post-op adhesions. The depth of penetration is limited to the targeted tissue within a diameter of 1 millimeter, and it minimizes smoke for improved visibility. Next, please. So for your instrumentation for suturing and tissue anastomosis, you have your needle drivers. Lap needle holders have one fixed jaw and one jaw that opens by squeezing the spring-loaded handle of the instrument. Some possess features allowing the jaws to rotate around the main axis. And for your articulating needle drivers, they aid in obtaining more optimal suturing angles with the needle. And the actuation of your articulation is controlled by wrist motion. So for your endo stitch, they are disposable 10 millimeter instrument that facilitate lap suture placement and knot tying. And then you have your laparoscopic clips. These clips act as a knot, precluding time-consuming intracorporeal lap knot tying. And they can secure anchoring of sutures for up to 14 days in low tension to mid-tension environments. So here you have a picture of your laparoscopic clip. Next, please. For your barbed suture, knotless barbed suture is an innovative type of suture that can accelerate the placement of sutures and eliminate knot tying. It's designed monofilament suture with barbs oriented in the opposite direction of the needle allows suture to grab the tissue without the suture sliding back. For instrumentation of stapling and clipping, device occlusion and division. When laparoscopic staplers are used, special attention must be paid to the markers on the cartridge to ensure that all the targeted tissue is properly situated proximal to the markers before the cartridge is fired. The stapler should not be fired across any previously placed clips because this is thought to possibly cause stapler malfunction. So there are also powered staplers, and they are thought to increase the stability and enable more precise stapling relative to manual staplers. So these are your examples of the knotless barbed suture. At the top left, and your stapling device at the bottom. And on your right, these are different handle designs for commonly used lap needle drivers. Next, please. So for your clipping device, these are either disposable or 1 millimeter laparoscopic ports. You have your disposable, and they have a rotating shaft and multi-fire and have self-reloading features. And for your non-disposable, they have to be reloaded for each clip to be deployed at the site of surgery. Electrocoagulation must be avoided in the vicinity of the clips placed for occlusion of vessels to prevent conductive tissue necrosis and clip dislocation. For instrumentation for specimen entrapment, it depends on the site of the tissue and whether in situ morcellation or intact organ retrieval is planned. So you have your lap sac made of nylon with polyurethane inner coating and polypropylene drawstring, and it is the least susceptible to tearing or leakage of cells. Next, please. There are also other entrapment sacs available with marked advantages when the only goal is organ entrapment and intact removal. They have spring wires that, when activated by the surgeon, deploys the bag after introduction to the abdomen. This facilitates tissue entrapment because the broad wire supports stabilize the open sac allowing the surgeon to scoop the specimen into the sac. For instruments for morcellation, the simplest method for fragmentation of tissue within the entrapment sac is the use of the index finger, ring forceps, or Kelly clamp. The ring forceps are the preferred instrument for manual morcellation because they are less likely to puncture the entrapment sac. For your robotic instrumentation, for the Da Vinci robotic system, ENDRIST offers articulation at the tip of the instrument with 7 degrees of freedom and 90 degrees of articulation, mimicking the wrist movements of a surgeon at the robotic console. So for instrumentation, for incising and hemostasis for your robotic instruments, ENDRIST scissors for incising tissue include the round tip and pot scissors. Monopolar and bipolar electrocautery instruments are available for incision, dissection, and hemostasis. So for instruments for grasping and blunt dissection, the most commonly used grasper in urologic procedures is the ProGrasp blunt forceps. And a safety feature on all the robotic grasping devices is a small Allen bolt that can manually open the jaws of the instrument in the case of robotic arm malfunction or loss of power, in which the grasper is locked onto the tissue or a needle at the time of failure. So for instrumentations for suturing and tissue anastomosis, you have 4 different ENDRIST needle drivers available and 2 sizes of needle drivers available in the standard and suture cut design. Your suture cut design allows the surgeon to cut the suture material using the crotch of the instrument. And you also have other 8mm or 5mm instruments. The endo wrist clip appliers exist for small titanium clips, and medium, large, and large WEC HEMOLOC polymer clips. An articulating suction device and irrigator, probe stabilizer, and specialty retractors also exist. Next, please. So here you have your WEC HEMOLOC clip and the tip of the laparoscopic applier on your left, and the metal clip, and WEC HEMOLOC clip affixed to a suture on your right. Next, please. So for exiting the abdomen, for port removal and fascial closure, before port removal is initiated, the operative site and the intra-abdominal entry sites of each cannula must be carefully inspected with the intra-abdominal pressure lowered to 5mm mercury. After achievement of the perfect hemostasis, removal of all laparoscopic ports must be undertaken strictly under laparoscopic visual control to avoid any possible acute herniation of the intra-abdominal contents into the previous port sites. After inspection at 5mm mercury, the first 10 or 12mm port is removed and the fascia at the entry site is secured with an oovicryl, either by direct placement of a fascial suture or the use of a suture passing device. So 5mm ports are not closed in the adult but are closed in the pediatric patient with a single absorbable suture. So after removal of all ports, the CO2 is allowed to pass out passively through the 5mm port sites. And the hand assist device should be removed before removal of the other port sites. The hand assist device wound is then closed as one would typically close the abdominal wound. After closure, the pneumoperitoneum is re-established and the other port sites are closed as previously described. So for your instrumentation for port site closure, the simplest method is to retract the skin with retractors, grasping the fascia, and suturing it with absorbable OO sutures. For closure of the skin of all 10mm port sites are closed with subcuticular 4O absorbable sutures. Adhesive strips are applied to all port sites to close those less than 10mm or to further approximate those incisions more than or equal to 10mm. And alternative octyl cyanoacrylate glue, it speeds closure time and provide an equivalent cosmetic result.
Is that all for today, guys?
Hindi po, Doc. May next po. Natanggal lang po.
Ano yung
Uh,
physiologic screenings?
Physiologic consideration. For the physiologic considerations in the adult, first, insufflation is the introduction of gas into the abdominal cavity, which establishes a state of hemorrhage, thus creating proper visualization of the abdominal contents during laparoscopy. So we use different types of gas in insufflation. First, we have the carbon dioxide. It is the most commonly used insufflant for laparoscopic and robotic surgery. It is favored by most minimally invasive surgeons due to its properties, like it is colorless, non-flammable, and very soluble in blood, and it is inexpensive. It has a higher solubility than air and in water, which makes it more easily diffusible in body tissues, and it readily moves out of the peritoneal cavity as a result of a high diffusion burden, thus reducing the risk for complications. Next, we have the nitrous oxide. It is less irritating to the peritoneum and causes fewer acid-base changes and cardiovascular adverse effects like arrhythmias than carbon dioxide. But in some studies, it reduces cardiac output, increases MAP, heart rate, central venous pressure. It is also flammable, and it cannot be used when using electrosurgical equipments. Next, we have D-helium. It is an inert and non-combustible insufflant used for the patient with pulmonary disease in whom hypercapnia would be poorly tolerated, but may be associated with a higher risk of gas embolism because of its lower blood solubility. Other insufflants include room air and oxygen, which are used to establish a pneumoperitoneum in the past embolus into abdominal explosion, combustion with oxygen and room air, and have been terminated their clinical use. So for the use of pneumoperitoneum pressure, 15 millimeter mercury is the most selective pressure for performing laparoscopy or robotics. 12 millimeter mercury is used as more optimal because this results in no perseverances in cardiac parameters like no exchange in stroke volume. Lower pneumoperitoneum pressures has also been found to reduce post-operative pain, while 10 millimeter mercury has been shown to result in a marked reduction in oliguria, pressure of 8 millimeter mercury during renal surgery when using a valve-free TROCAR system with an intelligent flow system insufflator, and a pressure height of 20 millimeter mercury has been noted to reduce 2% increase insufflant filling volume and possibly less venous bleeding during the procedure. So cardiovascular effects of the pneumoperitoneum. First, we have effect in the venous flow. So the effect of pneumoperitoneum on venous flow and venous return and its reflection of the hydration state of the patient. If the atrial pressures are low, like during a pneumoperitoneum of up to 20 millimeter mercury, venous return is reduced because of increased compression of the vena cava from the pneumoperitoneum. If atrial pressures are high, the vena cava resists elevated intra-abdominal pressure and venous return is enhanced. Next is cardiac arrhythmias. Tachycardia and ventricular extrasystoles may be seen as a result of hypercapnia. And peritoneal irritation may lead to vagal stimulation and subsequently to bradyarrhythmias. And these arrhythmias can serve as clinical warning signs for the occurrence of pneumothorax, hypoxia, and gas embolism. Another effect would be the unreliability of CVT readings. Intravenous pressure may actually rise with low abdominal pressures, and increasing intra-abdominal pressures may artificially elevate central venous pressure readings owing to an increase in intrathoracic pressure. Next, we have the respiratory effects of pneumoperitoneum. Diaphragmatic motion is limited because of increased intra-abdominal pressure, and the average peak airway pressure needed to keep up a constant tidal volume increases parallel to the increase in intra-abdominal pressure. Next, we have non-pressure related respiratory effects like the head-down position, which is commonly used in laparoscopic and robotic procedures, and it has an adverse effect on respiration. It elevates the diaphragm and decreases the vital capacity and can lead to a dislocation of the endotracheal tube that may cause right main bronchus intubation. So next, we have the renal effects of the pneumoperitoneum. Increased intra-abdominal pressure has a significant decrease in urinary output, causing oliguria and anuria. Decreased renal vein blood volume, blood flow, and direct renal parenchymal compression. So to avoid oliguric state during laparoscopic procedure, pressure of 10 millimeters mercury or less is recommended. Also, furosemide, mannitol, dopamine can help overcome oliguria. Next effect of pneumoperitoneum on mesenteric blood flow and intestinal motility. First, there is decreased blood flow during laparoscopic procedures, and it was found in mesenteric vessels and other organs like the liver, pancreas, stomach, spleen, small and large intestines. And open incisional abdominal surgery usually results in some post-operative impairment of gastric and intestinal emptying because of intestinal paralysis. It has no significant effect on gastrointestinal motility pattern, thus resulting in no post-operative physiologic use. So next we have the acid-base metabolic effects of pneumoperitoneum. Prolonged laparoscopic procedures may result in hypercapnia and respiratory acidosis. Also, intermittent arterial blood gas sampling should be performed in patients with COPD during any laparoscopic or robotic procedure that requires more than an hour of carbon dioxide insufflation to ensure proper monitoring of acid base. Next, we have the hemodynamic effects related to patient position. In supine position, cardiac output remains unchanged or decreased when intra-abdominal pressures are less than 15 millimeters mercury, whereas MAP and systemic vascular resistance increases. In head-up position, heart rate and systemic vascular resistance increases while the MAP and cardiac output decreases. And in head-down and Trendelenburg position, heart rate drops, MAP increases, systemic vascular resistance falls, and cardiac output. We have hormonal and metabolic effects during laparoscopic surgery in beta-endorphin, cortisol, prolactin, epinephrine or epinephrine, and dopamine are increased during laparoscopic surgery as a response to tissue manipulation, intraoperative trauma, and post-operative pain. Serum arginine vasopressin is also increased in open surgery and in response to intraperitoneal laparoscopy. Metabolic changes observed during open cholecystomy are the following: reduced post-operative plasma glucose elevation, less decrease in insulin sensitivity, and reduced hepatic stress response. A wide spectrum of inflammatory response mediators like the C-reactive protein, interleukin-6, and other markers of cellular immune functions like the pan T cells, helper T cells, suppressor cells, and natural cells, delayed serial phytohemagglutinin-induced T cell proliferation are less suppressed. So next, we have the complications and troubleshooting in laparoscopic and robotic surgery. So incidence of laparoscopic complications in urology has been in the range of 4%, and mortality has been distinctly unusual with a rate of 0.03% to 0.08%. For the major complications of transperitoneal abdominal surgery, here you can see that overall complications are increased in pelvic procedures, and also the intraoperative and postoperative complications are increased in the abdominal. The others are others like death, vascular injury, bowel injury, organ injury are increased more in abdominal. The same or for the conversion rate of abdominal and pelvic. So to minimize the incidence of complications during the learning curve, it is advisable and recommended that the minimally invasive surgeons seek training in in-depth instructional courses, like including didactic, live case transmissions, and hands-on laboratory sessions, preceptor trainings in which the surgeon trains use 5 or more procedures being done by an already skillful laparoscopic or robotic surgeon, and in mentoring experience, which during a trained laparoscopic or robotic surgeon oversees the initial procedures performed by a surgeon in training. So we have the general procedural complications. First is the malfunction of equipment. So for a laparoscopic or robotic procedure to be successful, it is advisable that not only the psychomotor technical skills of the surgeon must be increased, but also on a proper working knowledge of all the equipment in performing these procedures. And also, to ensure undisturbed functioning of all technology, the surgeon must be supported by well-trained staff who are good in recognizing the equipment malfunctions, also in providing immediate adequate response to correct the problems. Next is complications related to obtaining the pneumoperitoneal, associated with the closed technique or the varus needle placement. First complication is the preperitoneal placement with the first sign as a steep rise in pressure with only 500 ml of carbon dioxide, plus if more carbon dioxide is instilled, unequal distension of the abdomen occurs. Next complication would be vascular injuries, and it happens during initial placement of the varus needle at the umbilicus. Minor or major intra-abdominal blood vessels may be punctured, and first sign of injury is blood appearing in the hub of the needle. Next, we have visceral injuries. Intra-abdominal organs may be punctured, and the initial sign might be aspiration of blood, urine, or bowel contents through the varus needle, or in the case of a solid organ, high pressure on initial insufflation. So next, we have complications during the open access or the Hasmus technique. It's a technique for the varus needle access, but principal risk is injury to an underlying viscera while traversing the peritoneum. The bowel may be adherent to the underside of the abdominal wall and therefore may still be injured in a densely scarred abdomen. Next, we have complications related to insufflation and pneumoperitoneum. So, first complication would be bowel insufflation, and the first sign of this problem is asymmetric abdominal distension, followed by flatus and insufflation of only a small amount of carbon dioxide. Gas embolism is there is an abrupt increase of end-tidal carbon dioxide and is accompanied by a sudden decline in oxygen saturation and then a marked decrease in end-tidal carbon dioxide. Next is barotrauma, caused by prolonged elevated pressures due to insufficient and infrequent monitoring of carbon dioxide pressure, malfunction of the insufflator, or additional pressures produced by auxiliary devices. Next is subcutaneous emphysema, develops as a result of improper placement of the varus needle or more commonly to leakage of the carbon dioxide around the ports. Next complication, we have the pneumomediastinum, pneumothorax, and pneumopericardium, which are caused by gas leaking along major blood vessels through congenital defects or secondary enlargements of openings in the diaphragm. Next complication, we may have related to initial blind placement of the first trocar after obtaining a varus needle, pneumoperitoneum. So we could have injury to gastrointestinal organs, perforation of the small or large intestine during primary port is the most common cause of trocar-induced injury of gastrointestinal organs. Next might be an injury to intra-abdominal vessel, but major vascular injury is a rare complication. Aorta and common iliac arteries are most frequently involved and common in procedures related to the retroperitoneal. And the first sign is sudden hypotension and associated tachycardia. Next, we could have an injury to urinary tract, and it is most commonly associated with trocar passage, specifically injury to the bladder at the time of initial trocar placement, and the complication to be related to placement of secondary trocars, and it may show bleeding at the sheath site and blood dripping from the port entry site into the underlying abdominal viscera is the first sign of an injured abdominal wall vessel. Next would be trocar position related problems like crossing swords, striking handles, and roll over. In crossing swords, the intra-abdominal portions of two trocars cross each other so that the two trocars cannot be easily used to deliver instruments to the same surgical site. For the striking handles, upper portions of the trocar strike one another on the abdominal surface. And lastly, the roll over, the primary cannula holding the laparoscope and one of the instrument holding secondary ports are pointed towards each other. Next complication might be related to the surgical procedure. So we could have electrosurgical bowel injury, and this may occur due to inappropriate direct activation coupling to another instrument, capacitive coupling, and insulation failure. We could also have cardiac arrhythmias and cardiac arrest, and the most common is sinus tachycardia. Next, we could have changes in blood pressure, wherein hypertension may be caused by inadequate general anesthesia, elevated intra-abdominal pressures, or hypercapnia. And hypotensions may be a result of hypoxia, pneumothorax, pneumomediastinum, gas embolus, or hemorrhage. Next, we could also have aspiration of gastric contents. This occurs more frequently in patients with hiatal hernia, significant obesity, diabetes, or the history of gastroparesis or any form of gastric outlet obstruction. And hypothermia due to prolonged laparoscopic procedures, especially if there is leakage of insufflant around the port site. Also, we could have mechanical bowel injury, vascular injury, wherein there is direct major vascular is rare. Next, we could also have nerve injury, which is a result of patient positioning in combination with duration of the procedure, and injury to the urinary tract, pancreas. With open surgery during laparoscopic or robotic surgical procedures, the urinary tract, spleen, or pancreas may also be injured. Next, we could also have related to complications related to exiting the in of the peritoneal momentum of bowel, and we could also have bleeding at the sheath site. So in early post-operative complications, pain may occur. Port site dysfunction is expected post-operative. Lateral injury, result of thermal damage caused by dissection, using monopolar electrocautery in the immediate vicinity of the ureter. Pancreatic injury due to the mechanical retraction during left-sided while 5 millimeter in pediatric patients with symptoms localized discomfort, nausea, and signs of illness could also have venous thrombosis and pulmonary embolism due to decreased venous return and therefore increased stasis. When laparoscopy and rhabdomyolysis prevention by avoiding use of the rest or using it for only the earliest part of the phase and avoiding prolonged such as pelvic lymph node dissection, radical prostatectomy, and Salix ascites common in the initial 2 days after laparoscopic procedure because of the pneumoperitone irrigation fluid or so wherein materials used include a box with an opaque top that is suitable for placement of laparoscopic parts in a vision system consisting of a video monitor, a light source, and a camera or camera lens combination. Could just do more realistic conditions, including more accurate anatomic relationships of tissue and the necessity for hemostasis that does not exist in inanimate models like the laparoscopic training boxes. While disadvantages include requirement of extensive resources such as veterinary personnel to care the animals, and eventually euthanasia of the animals. Next, we have the cadaveric models, which are better and more realistic for learning. So this is the example of the laparoscopic. CD monitor and track progress over time in terms of precision, economy of motion, and other parameters of it.
Thank you, Dr. Krista and Monica. So I have no questions, but I can share some insights. So I know this is a very long and boring lecture, but I'm sure this is the first time you've heard of this kind of lecture. But these are actually um, I think there are only 3 Da Vinci in the Philippines: PGH, Global, St. Luke's, and TMC. So matagal pa. But the patent is uh, eventually in China. So eventually, dadami na yung machines. So I want you to familiarize with regards to what the last lecture, applications, metabolically and intraoperatively. So you should be familiar with that. Hindi ito actually, this shouldn't be new to you guys anymore. So I know wala kayong experience, but this is very basic for us surgeons. And I think as prime parts in your rotation kasi makikita niyo talaga yan ang ginagawa namin. Unfortunately, due the same. Then kayo yan din yung mga questions. So good lecture, guys. Meron pa ba tayo? Or last na yun?
Last na po yan, sir. Next Wednesday.
Sorry, we forgot. Di kasi natin nilagay sila na holiday eh. Supposedly, we shouldn't be having lectures on a holiday, but nakaschedule na kasi natin eh. Meron pa ba tayong actually holiday din ng Wednesday, QC day. Tsaka ngayon, but sorry for that. And thank you for the lecturers. Do you have questions? I heard you guys are coming in September. Tama ba yan?
Sir, ano po, pending pa rin po kami ngayon, sir, kasi po may bagong labas na APMC guidelines, pero wala pa pong nilalabas na statement ang vet, sir.
Okay. I think mas safe naman kayo dyan sa bahay. And as far as our rotation, wala din naman kami. Oo. Ako na lang pala. Wait lang. Ay, hindi kasha. Celine, pa screenshot naman. Tapos pa-send na lang sa kay Daryl. Okay na.
Ano po, sir? Thank you.
Bye.
Thank you, sir. Enjoy din po.
Thank you.